Hello, everybody. Thank you for joining us for our didactic session, which we've titled Resident-Led Health Equity Initiatives. We're a group of either current or former emergency medicine residents from around the country, and we'll introduce ourselves in just a moment. The plan for today is to talk about some examples of resident-led health equity work, and then some of the things that we've learned along the way.
So to start by introducing ourselves, I'm Anita Chary. I'm one of the incoming chief residents at the Harvard-affiliated Emergency Medicine Residency in Boston.
And I'm Emily Manchanda. I'm currently an assistant professor of emergency medicine at Boston University School of Medicine, and I work clinically at Boston Medical Center. And I did my residency at the Harvard-affiliated Emergency Medicine program with Anita.
My name is Rosny Daniel. I'm an assistant professor of emergency medicine at UCSF. A first-year faculty member there, a former resident there, former chief resident, and formal medical education fellow at UCSF.
My name is Utsha Khatri. I'm a fellow in the National Clinician Scholars Program at the University of Pennsylvania. I also did my emergency medicine residency training and my chief residency at the University of Pennsylvania.
Hi, I'm Jessica Faiz. I am one of the rising chief residents at Boston Medical Center Emergency Medicine Residency in Boston.
Hi, I'm Amy Zeidan. I'm currently an assistant professor at Emory University, and I did my emergency medicine residency, chief residency at University of Pennsylvania.
Awesome. So we've got a whole group of former chiefs or rising chiefs. So the plan for today is really to talk about some examples of resident-led equity and inclusion work at each of our institutions. We're going to share with you some of the things that we've learned along the way in terms of what has worked well, what some of the challenges were, things that may help you if this is something that you're looking at either doing yourself or supporting in your residency. And we had planned to have a lovely lovely discussion with back and forth with the audience. Obviously, coronavirus has put everything on hold for group meetings, but we hope that you'll be able to learn something from what we have done along the way. One thing that I just want to mention up front, Anita, if you want to just go to the next slide, is what this talk is not. So we're not planning to define for everyone what we mean when we say unconscious bias or microaggressions. Some of those definitions are available in the handouts that accompany this recording, but we're not going to do a real diversity 101. We're sort of expecting that people who are interested in watching this and learning about this have some understanding of the basic concepts that go along with diversity and inclusion work or health equity work in general. All right, so amongst us, we had identified sort of 6 pillars or areas in which residents around the country have worked on programming for diversity, equity, and inclusion. Those include recruitment, didactic content, episodic diversity trainings, mentoring, both peer mentoring and mentoring from faculty, scholarship and research, and then clinical policy change. So through each of our experiences, we're going to touch on those areas and highlight some of the things that we've done. Before we get started, I just want you to do a quick thought experiment and think back to where you trained if you're not currently a resident, or if you are, where you're training right now. And just ask yourself whether there have been any initiatives that center around diversity and inclusion and health equity. Think about what those are, think about what those have involved. And then I want you to just think about who has led those efforts. In many cases, and at many institutions, certainly where we all train, those efforts have been led by people in their early phases of their career. Sometimes those are medical students who are asking tough questions that prompt sort of group conversations. Sometimes those are residents who are leading more structured interventions or conversations. And sometimes those are early career faculty. But many of these topics are relatively new to the world of emergency medicine and to medicine in general. Not to say that we're the first people to think of them, because we certainly are not. But having open and broad conversations about these is something that seems to be a little bit more common amongst the early career physicians. We want to just mention that these efforts, even though they're led by people who perhaps in the hierarchy of medicine don't have the most power, can nonetheless be incredibly transformative, and that having the early career physicians asking typical questions, investing their time and energy into solving some of these really challenging problems can be really powerful. All right, we'll have Rosny kick it off, talking about some of the work that he and others have done at UCSF.
All right, if we can go to the next slide. So thank you for that excellent introduction into what this talk's about. It's been really great to work with all these folks and see the pillars that a lot of us are kind of finding in common with each other. I'll briefly just mention some of the efforts at UCSF, and mostly speaking about resident ranking and recruitment as well. So the next slide. So in terms of recruitment, we have, like many other institutions, a underrepresented scholarship. So folks who want to come to UCSF to do a sub-internship and kind of get involved in our residency in the first place can apply to get a scholarship that helps with housing, food, et cetera, while people are visiting on their sub-internship. And during sub-internships, we have a specific email that we send out to the entire incoming sub-I class to just let them know, hey, we're very excited to have you here at UCSF and San Francisco General rotating with us. And we want to let you know that we care a lot about many things. And one of the biggest pillars for us is diversity, equity, and inclusion, both within our residency and as that kind of spills over into how we care for our patients and our community. So we definitely let people know up front that that's something that we want to do and that we care about. And we also have a recruitment happy hour for our underrepresented students. Those are people who identify as underrepresented, whatever that may mean in their mind. So it's kind of open-ended. And I think a lot of people understand what that means. We provide a little bit of like a definition. People see that when they apply for the underrepresented scholarship as well. But just in general, just letting people know like, hey, we're here. We want to talk about some of these issues that are very important to you. And it's something that we're thinking about. We make it very explicit and put it up front. The other thing that we do in terms of recruitment is we actually bring people back for a second look day. So after we've done our whole ranking process, which I'll talk about on the next slide, we specifically bring people back for an underrepresented second look day, which is sponsored by the School of Medicine at UCSF to bring back, I think we usually have about 5 to 10 people per department that chooses to bring people back for that second look day before the actual ranking process for medical students who are entering into residency. Can we go to the next slide? Great, and just to mention ranking, I think that this is one of the hotter topics in medical education and amongst academic programs in general. Ranking is very difficult, we all know that, and it's very hard to put people on a list from 1 to 100 and know exactly who's the best and put that ranking from top to bottom. One thing that we've done is worked really hard to create more of a holistic ranking mechanism, which means we're not just focusing on people's grades, we're not just focusing on people's test scores, but really thinking about what do they do and what type of person are they. It's very difficult and it takes a lot of time and investment to read people's applications kind of front to back. At our program, all residents are welcome to participate in the ranking process. The requirement is that you have to read the top 100 applications front to back. And I think the result of that, which is really cool, is that we start to get people who really fit with what our mission statement is. And our mission statement involves caring about those who are underserved in our community and also about diversity, equity, and inclusion. So we start to see a lot of people on our rank list rising to the top who really fit with our program in terms of work that they've done for diversity, equity, inclusion, work for their communities, and people who are interested in continuing that work moving forward. So with that, I'll stop and pass along to our next presenter.
Great, thanks Rosny for sharing your recruitment strategies at UCSF. At Boston Medical Center, we have adopted many of the same initiatives with tangible progress in diversity recruitment to the EM residency over the past 4 to 5 years. Some things I might add, we also do some targeted outreach to underrepresented minorities prior to each interview day, which gives them an opportunity to ask questions and introduce our committee. During recruitment season, we have our interview socials for everyone held deliberately at locations that showcase the diversity of Boston, thereby kind of making everyone feel welcome. And on interview day, we have adopted some structured interview questions to decrease bias, as well as including resources for minorities to thrive in the community. So however, We know that the lack of representation starts way before the residency application process, really back to early education. So myself and some of my co-residents entered residency with backgrounds and interest in teaching, and wanted to address this disparity by creating a pipeline program. So we partnered with a medical student organization at Boston University that was already doing programming, exposing Boston public high school students, the majority of whom are from low-income neighborhoods and of underrepresented minority backgrounds, to science and medicine topics. The students come to our hospital campus, and as residents, we augmented their curriculum with our clinical perspectives. So for example, after they go to the anatomy lab to look at lungs and hearts, we discuss like the physiology of penetrating trauma and brought in ultrasounds for them to like echo their own hearts. We also cover a variety of public health topics and promote exposure to other health careers by bringing in members of the emergency department, like social workers, nurses, physician's assistants, so the students are aware of the multitude of options they have. So by leading these sessions, we also provide opportunities for mentorship and shadowing, which many of the students would otherwise not have access to. So especially as a resident with time constraints and crazy schedules, this just goes to show that you can be creative and you don't need to reinvent the wheel. Partnering with this medical student group really allowed us to form relationships with community organizations like their SNMA chapter, local college minority pre-med groups, and even Boston Public Health Commission, like mentoring organizations. So we're not only spreading knowledge of science and medicine, but also that of emergency medicine as a specialty, and these students are the future of our specialty.
That's awesome. Yes. Thank you so much for all of that. It's incredible work, and it's great to know that residents are really leading a lot of these efforts to push some of these additional supports for recruiting and drawing, especially into emergency medicine, more people from underrepresented backgrounds. In terms of talking a little bit more about diversity training and then touching a little on scholarship and research, we're going to turn the mic, proverbial mic, over to Utsa first, and then to Amy to talk about the work they've done at the University of Pennsylvania when they were residents.
Thank you so much, and thanks for giving us an opportunity to talk about our experience. If you could please go to the next slide. So we want to talk a little bit about the didactic interventions we developed at the University of Pennsylvania that really focused on implicit bias training. And before we get into that, I just want to recognize that even as we were developing these interventions, we discussed that implicit bias training alone really isn't a sustainable solution. We know a lot of the racial and ethnic inequities that plague our system are deeply rooted in structural and systemic institutions. And we know that some of the biases are explicitly held, but even, considering all of that, as residents, when we were trying to think about what can we teach or explore amongst our peers that would make a difference in how they interacted with patients shift after shift, we really thought and read into the implicit bias literature and thought this would be a good intervention. So what we did was both Amy and I partnered with our institution's House Staff Quality Council. We had champions from other specialties as well as the Advanced Practice Provider Program. And we developed a curriculum where the first 15 minutes of the session involved having all participants take the Harvard Implicit Association test. And then after that, there was a 45-minute discussion that was led by a facilitator who used a facilitator guide adopted from the Baylor College of Medicine. And we were able to collect some survey data, as well as record the sessions to analyze for qualitative themes. And we found that through participation in our session, the participants did exhibit increased awareness of implicit bias and how their own results could affect their care of patients in the emergency department.
So the second exercise is sort of similar in that it was meant to be an exercise that explored implicit bias during residency conference, but really allowed individuals to explore implicit bias through the lens of an archaeologist using objects and artwork rather than in a clinical setting. And we had hoped that this activity outside of the clinical environment would be more relaxed and unique for an opportunity for engagement. Ultimately, the purpose of an implicit bias exercise in a museum setting is to discuss objective versus subjective findings. This emphasizes that all individuals make assumptions that generate biases from the observer. And I should also give appropriate credit to the individuals who developed this curriculum, which was anthropology and archaeology experts at Penn Museum with residency leaders in internal medicine at Penn. Similar exercises have been done at Yale Medical School, but this was one of the first in a residency setting. So the exercise consists of 3 components: a pre-brief, a viewing session called deep description, and a post-session reflective discussion. I want to focus on the deep description part, as that's the major content of this exercise. This is where participants view and observe objects in a museum setting. And the participant is asked to observe an object and describe some of the aesthetics, and then discuss the history of the object. So for example, when viewing a decorative pot, an objective finding is this pot has a scratch, whereas the subjective finding is this scratch is from an individual who used the pot as a weapon for defense. So the goal of this is really to suggest that all individuals make assumptions based on subjective findings, and that implicit bias is almost inevitable and is not necessarily a bad thing, but important to recognize that all individuals have implicit biases, and some can be negative and some can be positive. So we did a pre and post test survey, and results demonstrated that 67% of participants had a better understanding of implicit bias after the exercise, and 61% of participants felt more empowered to address their biases. I should also comment here that this work was with the collaborative effort of a lot of different individuals, but having a colleague like Utsha who was able to sort of partner and do this together made it all that more successful.
Thank you very much, Amy and Utsha, for sharing that. So I'm going to chat a bit more about the pillars of didactics and of mentoring. So at the Harvard Affiliated Emergency Medicine Residency, we developed a health equity curriculum, and this included 3 components. One of these was health equity rounds, which is basically a lecture and panel series that's longitudinal, and our residents are protected from clinical duties to attend didactic conference. So during these health equity rounds, we talked about topics like disparities in coronavirus, actually, health disparities in COVID care. We also talked about things with a focus on our own practice environments, such as disparities in cardiology admissions, hallway care. So those were sort of some of the topics that we talked about in health equity rounds. We also have monthly journal clubs in our residency, and we decided to make several of the journal clubs health equity and diversity themed. So one of our journal clubs, we actually focused on the experiences of female emergency medicine residents in training and the disparities that they experience and how they are rated in terms of their competency by both faculty and nursing. We also held a journal club that talked about the challenges faced by underrepresented minorities in residency training. And the third major component of our health equity curriculum is a health equity retreat. So we had a retreat that was also built into our didactic conference time, which residents are protected for. And we started out with a lecture and interactive activity about race as a social construct. And we reviewed different types of discrimination and racism. So thinking about interpersonal racism versus institutional racism. And we actually had residents share their own experiences by writing in anonymously about their experiences of diversity in the workplace. And we had residents, just audience members, read those different quotes to make that an interactive process. We also had an microaggressions workshop. So this was basically introducing the concept of microaggressions and teaching residents some skills for how to respond to microaggressions when they face them, and also how to be productive bystanders and allies, and what to do when they're witnessing microaggressions happen to other people. And we also had, within our health equity retreat, a discussion about the role that race plays in the de-escalation of agitated patients, whether that's physical or chemical restraints. And we developed a tool that residents could use to try to maximize success rates with doing verbal de-escalation alone. So to comment a bit about the mentoring piece of this, These initiatives, since they were kind of spaced out longitudinally throughout the year, and they had a resident leadership group who were senior residents, PGY3s and PGY4s in our 4-year program. So this kind of spurred a lot of informal peer mentoring. So whenever residents who were among the juniors would feel that some sort of incident had occurred at work, they felt more comfortable coming to the seniors who had led these initiatives. And these initiatives also helped spur the creation of supportive group chats. So we have GroupMe and WhatsApp chats for peer mentoring, specifically for women within our residency, people of color, and women of color.
Great, thanks, Anita. So I'm going to briefly touch on some of the more research-focused work that we've done and talk about one particular project and how it's starting to shape some changes in clinical policies at one of our hospitals. Go to the next slide. All right, so I specifically want to just highlight a research project that was collaborative between the Department of Internal Medicine and the Department of Emergency Medicine at Brigham and Women's Hospital. And this project came out of internal medicine residents' observation that the demographics of patients admitted to the cardiology service with heart failure appeared quite different from those of the heart failure patients on the general medicine service. And it appeared that people of color were more disproportionately admitted to general medicine, while white men in particular were much more likely to be admitted for specialized cardiology care. There's a lot of data that shows that specialized cardiology care actually matters in terms of patient outcomes, and both at the national level and then also at the institutional level. So a group of internal medicine residents basically worked with faculty and pulled the data, and then reached out to the emergency medicine folks to talk about why this may be happening. So through a retrospective look from 2008 to 2017, there were 3,100 or so admissions for just under 2,000 separate patients who had been admitted to either cardiology or general medicine. The sort of review of their data was relatively comprehensive. We tried to control for everything that we could think of controlling for, including different rates of various comorbidities in terms of different rates of socioeconomic deprivation in terms of when they were admitted. And when you looked across the board, people who were admitted to cardiology services were much more likely to have been seen in a cardiology clinic in the past year. And those who were admitted to general medicine services, you can see highlighted in red here, were much more likely to be African American, to be Latinx, to be older, to be female, and to have a couple of other comorbidities. The other things that were controlled for in this model are those rates of socioeconomic deprivation, psychiatric disease, language preference, et cetera. So this all got published in Circulation Heart Failure last year, and raised a lot of questions about why this was happening and how this was happening and what we could do about it. We also, I should say, noted that there were higher rates of 30-day readmission for patients who were admitted to general medicine relative to those who came into cardiology. And you ended up in this sort of vicious loop. I mean, if you can just click to the next slide, where people who were admitted to general medicine were less likely to have cardiology follow-up, and that was the strongest predictor of readmission in and of itself. And you ended up in this sort of bad cycle if you were admitted to GMS rather than cardiology. You can click to the next. So the question of what do we do about this prompted a secondary study that is ongoing right now, where we're surveying all of the admitting team members, so the attending in the emergency department or PGY4, to ask about the extent to which somebody who's coming in with symptoms consistent with heart failure is a certain diagnosis. Do you think this is certainly heart failure, or do you think that there are other medical comorbidities that are contributing to their need for admission? And then asking about how much the patient or the providers are advocating, other providers are advocating for cardiology admission, to try to get at some of these sort of amorphous, more subjective things that are not necessarily recorded in the chart, so that we can understand why patients of color are being disproportionately admitted to general medicine. We're also pulling the same chart review information that got pulled in the retrospective study so that we can draw comparisons from both retrospective into the future now. I will say that data collection got somewhat interrupted by COVID. We were about 70% of the way towards our enrollment numbers, and so we're going to do an interim analysis and sort of see where we stand. that is ultimately going to hopefully give us data that will lead to evidence-based interventions, including guidelines for admission, so that we can help to standardize the process, remove some of the unconscious or implicit bias, and also just generally improve the care for patients who are admitted with heart failure. Perfect. I think the only other thing that we wanted to touch on just briefly is, before we jump into the discussion, is just acknowledging that there are many, many different ways in which residents can work on equity, inclusion, and diversity initiatives, both within their institution and beyond. We've just highlighted a few examples, which we hope will be helpful for people, but there are many different specific examples for people around the country. We couldn't include everybody in this conversation, but just wanted to acknowledge there's a lot of really important work going on in many different places.
So as all of us on the panel were putting together our presentations and talking about the work that we do, there were a few major points that we wanted to discuss. And these relate to creating culture change, support from leadership, and advancing one's career when working in diversity, equity, and inclusion. So I'm going to start out by posing a question to all of our panelists, but by directing this to Jess. And this is about what you think culture change truly requires.
Yes, I do think that this entire session really encompassed the truly multifaceted nature of promoting health equity in your residency program or your department. A lot of the things that I have experienced at my institution, I think a lot of you guys share as well. I'll be speaking from my experience at BMC. So, 4 or 5 years ago, the initiative started as a diversity recruitment group of like 4 residents, and it morphed during my time there into what we call, I think appropriately, our JEDI committee, which is representing justice, equity, diversity, and inclusion initiatives. So I think that the name in itself kind of captures how it's not just one initiative that will transform the culture of your program. It's really multiple things. And with that, you need a team. So that group of 4 people really expanded to almost 20 residents. And in addition to recruitment, kind of like what everyone else talked about, it expanded to outreaching to medical students, pipeline programs, pushing the envelope in terms of existing structures for the interview process and moving towards structured interview questions, which was very scary for some people initially, but kind of proved to reduce bias. We incorporated more microaggression trainings as well. And I think Anita mentioned this before, like a social emergency medicine dedicated journal club. And attending things like the annual diversity days is really like built into the budget now and a priority for admin and faculty to attend. So these are some examples of how our culture change has manifested. I do want to just really emphasize the point that it does take a team of people who are dedicated to this work, and it also took years. So there's still a lot to be done, but this is not something that is going to happen overnight. And even if you don't see an improvement over 1 year or 6 months, don't be discouraged, because we are really trying to change the status quo here. And this is difficult work, but those examples are kind of what helped our recruitment and kind of propagated amongst applicants, and I think really benefited us during this past interview season.
Thank you so much, Jess. And I also want to reflect this question to Utsha and Amy at Penn.
Thank you so much for sharing that, Jess. That's really inspiring. I think when we talk about culture change and reflecting on our own experience at University of Pennsylvania, when Amy and I think about how our didactic intervention really impacted the program, I think the best thing that it did was that it opened subsequent didactic conferences and invited speakers to talk on this topic. We as residents said, we think this is important that we receive formal education and discussion on these topics, and our residency leadership gave us the opportunity to take a stab at an intervention. But I think the subsequent training sessions, like the one Amy described at the museum, and then an invited speakership with Dr. Utsha Blackstock, who is, just a thought leader and a national leader on racial inequity training, I think it opened a door, which we're really, really proud of.
Thank you so much. We're going to look at our second area of inquiry, which is about leadership. And I'm going to turn this question to Rosny, who has basically been continuing this diversity, equity, and inclusion work since residency, then into fellowship, and now as a faculty member. So the question here is about what are the types of supports from leadership that are necessary to make these sorts of initiatives possible and well supported?
Yeah, I think that's a great point. I think that this can't happen without some kind of support from leadership. As we've kind of alluded to and mentioned, I think a lot of this work is done by people who are really early in their career, whether that be early faculty, residents, or even medical students. I know definitely at UCSF, the medical students have inspired a lot of change. One such thing they did was they had the die-in. This was several years ago, where people in white coats laid down and kind of brought attention to the fact that there's a lot of racial bias and inequity, especially in the kind of policing within our country. So that really inspired folks at UCSF and within the leadership to invest in our students and invest in the school and see what we could change. So one of the big things that changed actually is this multi-million-dollar investment into this idea of how do we support our students? How do we increase our knowledge in diversity, equity, inclusion? And it wasn't just within the School of Medicine that, trickled over into several departments as well. So fortunately, one of the things that we benefit from at UCSF is, I think, buy-in from the top down. So that's like the deans of the School of Medicine. It goes to the graduate medical education group as well, and then to the undergraduate medical education group. So I think having all those folks in positions of leadership actually be supportive really creates some level of sustainability. So I was involved in several kind of diversity and inclusion efforts as a medical student, and as a resident, I saw our program change quite a bit in terms of our recruitment strategies, what our actual residency program looked like and who was represented, what type of faculty members we're recruiting, how we actually built a mission statement during our residency, and those things have kind of continued on. It's been really great to see that change grow, and I know that it would not have been sustainable without buy-in from our leadership. So School of Medicine, our program director, our chair, our chiefs at our sites, et cetera, et cetera. And I think that's a really, really important thing, is that you can't sustain it without people at the top who care. We're going to, actually focus some investments and give people buy-down to do some of this work and value it. Give space at our residency conferences and didactics and journal clubs, et cetera, to learn about these things, and be willing to change the entire process of how we recruit and rank our students who want to come to our residency program.
Thank you so much, Rosny. And I'm going to ask the same question to Emily about support from leadership, what's necessary, what you've found to be helpful and facilitate success.
Yeah, absolutely. I mean, I think everyone's highlighted that you can't do this work. It's really challenging work. You can't do it without input and support from leadership. I just wanted to mention, some of the things that have worked really well for building support for this type of work. I think in emergency medicine and in medicine in general, most people, whether you went into this last year or 40 years ago, went into this because they want to help people. And I don't think that anybody would explicitly say that they don't support equity work. I think, and certainly in principle, everyone is interested in making our care and our world a more fair and equitable place. I just wanted to highlight that sometimes the language that we use around these issues can be really important when talking to people who are less familiar with issues around diversity and equity and inclusion. And just in the things that I've learned along the way, if you jump in and start talking about structural racism with someone someone whose only sort of framework for understanding racism is thinking about the Ku Klux Klan and interpersonal racism, that you're going to run into a lot of resistance because they don't understand what you're talking about. And so starting from a point of, you know, sharing definitions and explaining how these things are interacting in whatever space you're discussing can be really helpful. And just recognizing that terms like microaggressions are relatively new terms, and for people who went to medical school in the 2000s, you know, that might be a very familiar term, but for people who were educated prior to that, these are new concepts and not things that they're as facile and comfortable discussing. So just knowing your audience when you're talking up to leadership can be really important, and finding terms that are both understandable and make them comfortable to sort of bring them onto your team, bring them into your fold, can be really, really important.
Thank you so much, Emily. I'm going to turn to our last topic for our Pearl section, and that is about career advancement. So all of us started this work as residents, and we are hoping to build careers where we continue to examine diversity, equity, and inclusion. So I'm going to ask Amy and Utsha about your experiences going from residents to faculty, and kind of how you have strategized building a career around these specific areas.
I can comment a little bit first on the aspect of scholarship and publication. So obviously the goal of our work was not for the purpose of publication or scholarship. It was for many other reasons. However, it's really, I think, important to get the knowledge and transmission of your work out into the general emergency medicine public and to the academic medicine community as a whole. And so part of what we were able to do after both of these exercises is to sort of think about, even, you know, before when we were generating the content, was thinking about how we could study and examine whether this made an impact. And although most of our measurements were really short term, and we really wanted to do more long term evaluations, over that can be challenging. So with the bandwidth that we had, we did do some short term evaluations, which then allowed us to write about our experience and to publish it. And so we were fortunate to have people who really helped us think through study design and manuscript writing. So we were able to both publish and present both of these exercises.
Yeah, and related to that, and just to echo what Amy said, I think having the foresight that dissemination and evaluation of our intervention was really important, not just for our program, but to be able to share with other programs. We thought about how to design the intervention in a way that it could be evaluated. So I mentioned we had some surveys from the participants, and then we also had a qualitative portion where the discussions were actually transcribed for themes. And I think it was a little bit more work to both design an educational intervention and also think about how to evaluate it from a methodology standpoint. But looking back, I think we've learned a lot, not just from our intervention, but we've learned a lot about the process of research that we wouldn't have otherwise. And I'm actually, the fellowship that I'm in is a health policy and health services research fellowship. And my work now focuses more, less on providers and their bias and more on patient outcomes and access to care. But my involvement in this work early on in residency definitely has and will continue to inspire the subsequent research projects I involve myself in.
Thank you so much. And I'm going to ask the same question about career building to Rosny.
Thanks. I just wanted to add that to build on the points that have already been made, you know, one thing we need to recognize is that this is actually really valuable. Diversity, equity, inclusion. There's literature, not just from medicine, but also from the business world as well, that suggests that diversity is actually a strength, and it can increase things like productivity, satisfaction, patient outcomes, et cetera. So I think within this career building thought, you know, there's groups that now have chairs of diversity, and equity champions, et cetera. So there's actual positions that people now have and that oftentimes will have some buy down. So I think this is something that we can really focus on. It's not just about, doing research or being the person who's on the sedation committee, but I think that a lot of places are starting to recognize the true value of diversity, equity, inclusion. And that's a place that a lot of us can start thinking about, developing a career within that spot.
Thank you. And I'm going to turn it over to Emily for a brief comment as well.
Yeah, I just wanted to mention quickly, to build on what Rosny just said, that if you're still in residency and thinking about how you can incorporate some of this equity related work into a career, you should just think really broadly and creatively. I mean, there may be positions within the medical school that can facilitate buy-down if you're interested in medical education. There may be things within the residency leadership, and you can absolutely bring an equity lens to your work in training the next generation of physicians. But also think about sort of the administrative roles within the hospital. So there are people now on quality and safety committees who are doing quality and safety work and quality improvement work at the hospital level, at the institution level, at the health system level with an equity lens. And it doesn't necessarily need to be in your title. You can bring this lens with you and ask questions related to equity from those positions that sort of fit into more traditional models of what roles are. I think we will turn it over now to talk about some of the things that didn't work so well with the work that we've done, hopefully so that everyone can learn from these. So among the 6 of us, we identified 3 sort of main areas that we found challenging in doing this work. And so those were the sustainability of efforts, thinking about who's not included in some of these transformative processes, and then also wanted to acknowledge the minority tax that is placed upon the people who are trying to do this work. And so to start the conversation about some of the things that we found challenging, we'll go to Rosny first to talk about some of the issues around sustainability.
Great. So I think the sustainability thing, it's really difficult to always continue this work, especially if it's always being led by residents, because by definition, residency is either a 3 or 4 year process within emergency medicine, and then it's over. So if you don't establish an official doctrine or some paperwork that defines what you're going to do or what your group does, these things will just go away if you go away. So I think really taking the time to think about and kind of write out, well, what's your mission statement? What are the goals of your diversity group within your residency or within your faculty or whoever it may be? To have an official document somewhere is really helpful, or else you run into the problem of, as soon as the people who are gone who actually care about this, it's no longer sustained. And one more comment about sustainability, I think finding a way to work with leadership to really dedicate some of the budget and dedicate some of the funds consistently to this. So every year, how much money do you have for recruitment? How much money do you have for helping out with happy hours, maybe some food, or getting people, together for a second look or whatever it may be? Something that can be actually built into a sustainable budget as well.
That's great. Thanks, Rosny. I think the other important thing for us to consider when you're talking about this work is who is left out of the conversations and who maybe is not benefiting from some of these resident-led initiatives. So Anita, do you want to touch on some of that?
Yeah, so in doing our health equity curriculum at Hammer, one of the things that we consistently hear from residents is, we're really happy to have these trainings and initiatives and lectures, but we really wish that this would go beyond residents. And so there is a large desire among residents for faculty members to participate. And we do have actually a fair deal of faculty participation, but there's sort of a perception that we're preaching to the choir, that the people who are interested in these topics are the ones who are going to show up, whereas the people who maybe could potentially become allies but are less familiar, if these are voluntary activities for faculty to participate in, that they're not going to show up. And then the other issue that consistently comes up is that there is a request for us to engage other colleagues in the ED, whether that's our nurses or the people who are sitting, the techs, registration. So there's just knowing that we're a whole team in emergency medicine, and teamwork is so crucial to all of the care that we provide to patients. And so thinking about what are the best ways to engage with other groups. And I will say that we have started to branch out in some ways, in that we have had a lot of discussion within our residency about ways to improve relationships between nursing and residents. And we are now starting a joint task force with nursing at one of our hospitals to kind of improve relationships in that regard.
That's awesome. I think one of the important things to acknowledge also is the minority tax. So I'm going to turn it over. Jess, do you want to highlight some of these challenges? Maybe define for people what we mean when we say minority tax as well.
Yeah, so for those who might not be as familiar, the minority tax is really the disproportional burden placed on minorities, so that whether that be people of color, women, members of the LGBTQI community, to do all of the work that we have discussed in this talk. So that could be manifested as time away from studying or research productivity, or less financial compensation, and last but definitely not least, the emotional burden of being in this role and doing this difficult work. In our experience at Boston Medical Center, allies have really been invaluable in alleviating the minority tax. Something that has been especially helpful has been allies educating others and sharing resources with people who do not identify as underrepresented minorities, so that, for example, during interview season, the go-to person to answer all the questions about, where to go after shift, or where can I get my hair cut, and all these types of things is not left on only a couple of people. So that widespread education, so that everyone in the community can answer those questions and really highlight that this is a priority for people, has been very important. And then lastly, affinity groups to support residents has been really helpful. For example, there's a Men in Black group at Boston Medical Center to support Black male residents, and faculty members are part of that as well. And these affinity groups don't need to be limited to your residency or your institution. There are national organizations too, like EMRA, that have diversity inclusion groups that you can form connections with, and I feel I've connected with multiple people in this group because of that. And you can really look outside of your residency and your program as well, and really helps with, I think in that regard, mostly the emotional burden and some of those challenges that we can encounter.
That's great. Thank you so much. So we're about at the end of our time, and normally we would have had a more interactive session if we were all together in one room, but we want to invite you to share any questions with us, any things that you've learned, additional tips or strategies for addressing these really challenging but important questions. Please feel free to reach out. My email is here, and all of our emails are on the introduction slide as well. And you can also reference some of the handouts that we're providing along with this didactic. We look forward to hopefully seeing you soon, and wish you the best of luck with all of this work. Thanks, everyone.